Okay, I'm going to talk about the second international consensus meeting held in Morioka, 2014. I think, let me talk about myself. When I started the laparoscopic resection back in 1995, I had a fear for bleedings, of course, and I had a big stress with a poor ergonomic. But after I got this idea from somewhere, operation consists of imaging and manipulation. So if your image is better, your manipulation, if you overcome your manipulation, your surgery quality of your surgery will become better. Then I have come to this conclusion. Minimally invasive surgery has a better exposure because you can see it in front of you inside the abdominal cavity. Then I have come to this conclusion. Laparoscopic liver resection is better, superior with a better exposure with magnification and less bleeding with the pneumoperitoneum. So some concept has changed in this field because when you perform open liver resection, very dangerous area like vena cava and adrenal gland is just behind the liver, so you can't see well. However, if you place a laparoscope from navel bottom, you see those areas nicely, and also especially your hilar plate is sitting in front of you. So liver surgery can start hilar plate. I'm going to talk this in the afternoon. So we call this a caudal approach, and I ask graduate students to perform a pig model experiment. And if you increase the pneumoperitoneal pressure, your portal vein pressure also increases. However, if you increase the portal vein pressure, pneumoperitoneal pressure, your hepatic vein diameter will be reduced. That means soft liver can be shrunk by the pneumoperitoneal pressure. Then the pneumoperitoneal pressure can synergistically reduce the bleeding from hepatic vein with inflow occlusion like Pringle. Then you can achieve this beautiful bloodless parenchymal transection. This is one of the ideal liver surgery, in my opinion, exposing the medial hepatic vein wholly without having any blood in the field. And also, because the liver resection is done in a closed abdominal cavity, you can rotate the patient, you can head that the patient, and you can make a middle hepatic vein higher, right hepatic vein higher than vena cava. That also results in a reduction of blood loss from the right hepatic vein. And as you know, when we started LabColi, in several years, LabColi becomes very much propagated, like 90% cholecystectomy is done by laparoscopic way. However, if you perform a nephrectomy, it takes time, and a donor nephrectomy, after 9-10 years, it becomes kind of a little bit propagated, adopted. So what about liver resection in a laparoscopic way? So I think we are now at the tipping point. This surgery, laparoscopic liver surgery, might be gone because it's too difficult or too dangerous and no benefit for patient. So we have to define the value of this surgery. Randomized control trial is also the way to go. How we see the results from Professor Edwin. He did a nice COMET study and finished. But consensus meeting has some role in this field. And Joe Will, sitting next to me, held the first consensus meeting, Louisville, 2008. Then 6 years later, I decided to host the second consensus meeting using a new model of evaluation. So I asked Steven Strasberg to chair a jury, and one of the jury is Jeffrey Barkan. He published a nice idea about ideal definition like this. So we can categorize, we can classify the technology, surgical technology, grading from stage 2A, 2B, stage 3, stage 4, and ideal development phase, exploration phase, assessment phase. So 43 liver surgeons invited to Morioka, northern part of Japan, And we spent 3 days, very intense 3 days. And the purpose was to define the current role of lap liver surgery and to safely develop it for the sake of patient. What is the value and what the safety, what the quality? So these are the questions. What are the comparative short-term, long-term outcomes of lap liver? And what are the indications according to the difficulty of lap liver resection? Difficulty means a lot to define the indications. So what are the essentials for improving the quality of the surgery? So again, we applied Julius-Danish model, consensus model, and independent jury model based on a consensus model, because we are the expert, and we don't want to be unfair, because we are believer of this field. So we asked Stephen Strasbourg to chair the 9 people who are very much established liver surgeon, but not so enthusiastic to perform this surgery. So we'd like to have a balance. So this is how we did the presentation. They are sitting in front of us when I presented the data. So this guy, Ruben Sia, he used to work with me just before the consensus. He spent several months with me to learn lap liver surgery, and also he did a very much extensive systematic review before the consensus meeting. As you know, as you can see, many publications starting after the first consensus meeting and increasing annually. But the cases reported, over 100 cases centers are located only Northern America, United States, and Europe, and East Asia. Most surgery among the 9,000 cases are wedge resection, followed by left lateral and right hepatectomy. So 70% of liver surgery are reported a minor liver surgery. So only 24% are measured that time. And he did a very much extensive forest plot, and we found in the minor-only resection, overall complication rate, estimated blood loss, the transfusion rate, and hospital stay as superior in lap liver resection. For measure-only resection, overall complication rate, estimated blood loss, and the hospital stay as superior in a laparoscopic liver surgery. So I asked my younger colleague, Professor Tanabe, to create a scoring system for difficulty, and published before a consensus meeting. We discussed at the consensus meeting. So this is like a child poo score, and we define the tumor location and the extent of liver resection, and the tumor size, proximity of measure vessel, and the liver function, and we score 1 to 4, and finally we have a 1 to 10 score, high level index, and we defined a low level index is less than 10 cases. We suggest to start the low level up to 3, and intermediate, if you have experience over 10 to 50 cases, probably you can perform 4, 5, 6 level, and after you have 50 cases of experience, you can perform a 7. So for index surgery is 4 as a left lateral sectionectomy, and simple hemihepatectomy as defined as 7. So this is like a rock climbing. Beginners never go into the difficult rock climbing. So this is also this would result in the patient protection to a surgeon can select the patient as according to their skill set. So this is a main outcome published in Annals of Surgery last 2 years, and along this main publication we have almost more than 20 at now, mostly from a systematic review beforehand. And this is a jury recommendation, and this is a little bit very much, I don't know, not attractive, but you can read it, please. Minor and major, and the type 1 recommendation, type 2 recommendation, and categorize it as ideal 2A, ideal 2B. So also we have experts technical recommendation regarding general agreement, house and hybrid, conceptual change, SEO2 pneumoperitoneum, all those things. So, but I hope if you are interested, please refer this Annals of Surgery. But most important message from Second International Consensus meeting is to protect the patient from doing this from this newly developed surgical procedure by doing a prospective reporting registry for transparency and a difficult scoring system to select the patient, and the creation of a formal structure of education. That will result in the creation of a ILS by Daniel Shelkey. So poster session, people are very much happy about our gathering, and I think finally 240 surgeons are gathered in Morioka, and we spent very much extensive 3 days. So after the Morioka meeting, Japanese Society of HPV Surgery published 3 important papers using National Clinical Database to match the propensity score, and we found for major hepatectomy, even the major hepatectomy, blood loss is less, although it's a lot, and operative time is longer, but length of hospital stay, although it's long, but it's a Japanese way, 5 days shorter, morbidity is less. And mortality not different, and for long-term survival, a hepatocellular carcinoma, blood loss is less, and OR time is a little bit longer, but the hospital stay 3 days shorter, and morbidity is almost a half. And long-term, no difference. And same colorectal mets, blood loss is a little bit less, and hospital stays are 2 days shorter. And long-term, not inferior, quite similar. So we started online registry in October as following a recommendation of a Morioka consensus. And our government very much appreciated with this registry, and they set up some price for a new surgery, like, for example, right hepatectomy, two-sectionectomy, if you perform laparoscopic way, you can charge about 14,000 US dollars, but only 7,000 US dollars for open. So it has an incentive. That is a surgical fee, but those money never come into our pocket. It goes to the hospital. So at this moment and up to end of February, we have accumulated the 3,000 registry from 262 institutions. And I will introduce Professor Bjorn Edwin, a COMET study. He just showed us several weeks ago. And also this is also another important meeting hosted by Mo. And these are the experts, and these are the scientific committee who did a very extensive systematic review, and we validated the guidelines. This is going to be published in a year, I hope, in Annals of Surgery. So again, Daniel Shelkey showed his initiative to create a society, International Lap Liver Society. It's going to take place in July. And 2 years later, in Tokyo, May 9 to 11, 2019, I will be hosting this second ILS meeting in Tokyo. So please join us and to propagate this field safely for the patient. Thank you very much.
Thank you.